These lectures are titled Understanding the Human Body, An Introduction to Anatomy and Physiology, Part 1.
Welcome. I'm Dr. Anthony Goodman, and this course is Understanding the Human Body, an Introduction to Anatomy and Physiology. This is the first of 32 lectures in which we're going to study the anatomy and then the physiology of all the organ systems in the human body. We're also going to make correlations in the pathophysiology and the pathology, the abnormal structure and the abnormal function of systems of the human body. We're actually going to study this slightly differently from the way it's studied in medical school. Medical students dissect cadavers and they study regional anatomy. We're going to be looking at systems anatomy. The medical students need to know, for example, what organs and structures lie next to each other so that in the operating room, they will know where they have to be very careful, where they can make some time, and what has to be protected. They can't really study systems in a human body when doing a dissection. We can do that here. We're going to look at each system one at a time, and then we're going to compare the physiology and the diseases that can happen to that physiology. Today we're going to look at the heart and the structures that are part of the physiology of the heart. The heart used to, for centuries, define death. If the heart was beating, you were alive, and if it was not, you were dead. That was the legal definition, and it was the physiologic definition. Today we define it by brain death rather than heart death because of the advent of organ transplantation. But still, without the heart, nothing else would be working. So we're going to begin here with the heart of the matter and talk about this wonderful pump that can pump 20 gallons a minute, an enormous volume, which weighs less than a pound, which can go on for 100 or more years and rests a fraction of a second on every beat. It's a tireless, energetic organ that can pump approximately 1.5 million gallons per year, year after year, and rarely has any malfunction until the time it's ready to give out and the patient dies. We need to study in the beginning the types of circulation in the body, and there are generally two types of circulation. If we look at the first slide, you'll see the heart in the center. And this is highly schematic. This does not reflect the way it is anatomically, but basically we have two systems going on. We have what's called the systemic circulation, meaning the blood that is going out of the heart and feeding all the organs of the body. This shows schematically the brain, and down in the rest of the body, which would include the organs of the chest, the abdomen, the extremities, the muscles. That's the systemic circulation. Blood returns to the heart through veins to be pumped out again. There's a secondary circulation. After the blood returns to the heart, it needs regenerating. It needs to get air from the lungs, oxygen, needs to get rid of waste gases. So it's pumped out to the lungs where it is oxygenated and then returned to the heart. And that's called the pulmonary circulation. And these are two parallel and separate circulations that have a different function and a very, very different anatomy. In general, when people think about the heart and the lungs and the circulation, they think about arteries carrying oxygenated blood, and they think about veins carrying blood without oxygen. And that's not really a good definition. We come back to the slide. In general, the systemic circulation, that holds true. Blood leaving the heart, going to the body, or going up to the brain and the upper extremities, does carry oxygen. So those vessels in the arteries are carrying oxygenated blood. But if you look at the pulmonary circulation, the vessels going out to the lungs, the pulmonary arteries, are carrying deoxygenated blood. And the oxygenated blood is coming back toward the heart. So that definition doesn't hold very well. We really have to define arteries and veins by the direction of blood flow. Arteries pump blood away from the heart, including the pulmonary circulation, which is going away from the heart, and the veins bring the blood back to the heart. And here we have oxygenated blood coming back in the pulmonary veins. Now, the location of the heart is another area that is sometimes confused. People think of the heart as being on the left. We pledge allegiance with our hand over the left side. We make little hearts and fencing costumes over the left. The heart is really not on the left. It's in the dead center of the body. And if we look at the next slide, this is a cutaway view of the chest. Now, I want to get into a few definitions of how we look at these pictures. This is a view of different planes of the body that we're going to be using. The plane I just showed you is a frontal plane. It's as if we sliced the patient right up the middle, facing us. And we're looking at the heart through that frontal plane. We're going to also look in this section at a transverse plane, which cuts the body horizontally. And then we're going to look at sagittal planes, which cut the body up and down. Getting back to the position of the heart in the body, you can see that there is an enormous cavity called the thoracic cavity. This is the chest. It's bounded by the ribs. It contains basically three sections. It contains the right and the left lung on both sides. And then down the middle is the heart, occupying almost the entire center of the thoracic cavity. Now, it's absolutely right in the middle. You can see a little bit of the heart sticks over more on the left, but primarily it's a midline structure. And all three cavities are separate. The left lung here is in its own enclosure. It does not communicate with the heart in any major way. The right lung is in its own enclosure, and then the heart and the great vessels are in the middle. This middle area is called the mediastinum. And the only functioning structure in the mediastinum is the heart itself. The vessels leave the heart and go to their various places through the mediastinum, and there are a couple of other organs which traverse it. For example, the esophagus goes from the head down to the abdomen, but doesn't really do any business in the mediastinum. It's just a conduit. It's just a street. So we're really interested only in the heart by itself. Now, if we look at this through a horizontal section, taken right through the chest, we get some interesting anatomy. This is the patient's front, this is the patient's rear, and this is the right, this is the left. If you remember, when we looked at the sections, here's this transverse section again, also called a horizontal section, cutting through the patient. It is our convention to look at this on a slide or an X-ray or an MRI as if we're looking up at the section, so that the patient's right still comes out on the right, the patient's left is on the left. Now in this slide, this is the patient's right, showing the lung. This is the patient's left, and here's the heart sitting pretty much what we call anteriorly, or to the front. The opposite of that is the posterior portion, or the back. Look at the position of the heart relative to hard structures. Here's the sternum, or the breastbone, and here is where the backbone comes into the chest cavity. So you have two very firm, fixed structures on either side of the heart. The sides are pretty soft. That's where the lungs are. And if you think about what's over here, these are the ribs coming around the side. Now, the ribs are very flexible and compressible. And this brings us to our first clinical application, cardiopulmonary resuscitation. The heart is positioned right in the middle of two very hard structures with flexible structures on either side. This allows compression of the chest and the sternum against the backbone with the heart in the middle. In the old days, before we realized you could actually pump this way, we used to open the chest when it stopped. Somebody in a hospital or an emergency room had a cardiac arrest, we would go ahead, we would open the chest with a knife, the surgeon would stick his hand in and squeeze the heart with his hand. It was very efficient. It's actually more efficient than closed massage. But it was also very invasive, very aggressive. And there was a certain mortality, death, and morbidity, meaning bad complications, with that kind of massage. Today, still in the operating room, we use open massage if the chest is already open and the heart stops. It's also another way to start the heart. But in the absence of an open chest, we still go to cardiopulmonary resuscitation, in which, as you probably know now, we press on the sternum. The sternum has some give in it because of the ribs, and we are pumping the heart against the backbone and the sternum. The blood output is about 80% of what you can get if you did it by hand, but it's still adequate for good circulation and to resuscitate a patient. The next topic is the pericardium, the coverings of the heart. And this is a subject which is good to dwell on at this point because it's going to be very much related to other coverings in the body, and a good understanding of the embryology is really very important. The heart isn't sitting there in the cavity by itself. It's not sitting in the chest free, but as you can see, the cut edge here in this plane has a little sac around it called the pericardium. Pericardium, meaning around the heart, is a tough, fibrous sac that holds the heart in place and gives it some protection. It also protects the heart from overexpansion in diseased states. This is a two-edged sword. And the way it forms is really rather interesting embryologically, and it's exactly the way the coverings of the lung form, the pleura, and it's also analogous to the way the coverings of the intestines form. So it's worth a minute to look at that right now before we go ahead. If you can imagine yourself sitting in a closet or a coffin or a small room, and you represent the heart. And if you were to take a balloon, which is going to be the coverings, and start blowing that balloon up, the balloon would expand away from you until it reached the walls of the enclosure you're in, let's say a closet. It would then, as you continue to blow, press against the walls and line the walls, floor, ceiling of that closet. That's what we call the parietal pericardium. It is the wall, parietal means wall, covering. If you continue to blow, what's going to happen? The balloon is going to start coming back at you and press around your face and body as it has no other place to go. It's eventually actually going to meet behind you. That very thin layer that's covering you is what we call the visceral pericardium, and it's tightly adherent to the heart itself. Now think about that space. There's now a space between you, covered in this thin layer of pericardium, the visceral pericardium, and the wall, the parietal pericardium. And that's exactly analogous to what we have in the heart. There is a space, it's actually only a potential space, and it's filled with fluid, a lubricating fluid that allows the heart to pump without rubbing or being irritated by the pericardium. If you look at the layers that they show here, you can see the visceral covering of the heart. This is a section through the heart and the pericardium. Here's the cavity. It's only the potential space. And this is filled with a thin layer of lubricating fluid that's regenerated and renewed all the time. And then you have the layer of the parietal pericardium, the wall, the tough end of that. Now, this pericardial anatomy has some aspects to it that lead to pathology, things that we can get in trouble. While it has given protection to the heart, it also has the problem that there may be too much rigidity, too much protection. For example, you can get something called pericarditis. The suffix itis means inflammation. Appendicitis, for example, meningitis are all words you've heard. These just mean inflammation. Arthritis, inflammation of the joints. Pericarditis can be caused by viruses and other infections. And when the heart and pericardium become inflamed, they begin to rub and irritate. This causes chest pain. It can cause difficulty in pumping. It can cause the patient to have fever, infection, and other symptoms of severe illness. After the infection is over, the pericardium can scar down. This is called constrictive pericarditis and make it difficult for the heart to pump. The other side of this is what happens in our high-speed society. We have lots of things in our society that move at high speeds. One of them is the car, and we have steering wheels that are very close proximity to the chest. And in car accidents, before the advent of airbags, steering wheel injuries to the chest often caused injury to the sternum. And as you saw how close that was to the pericardium, tears or bleeding in the heart and pericardium. High-speed missiles that we get at the Friday and Saturday night knife and gun clubs, bullets, knives, clubs, also can injure the pericardium. And the result is that you can get blood in this little space right between the heart and its covering. If you look up here, that tiny little space is bounded by this fibrous, dense pericardium that doesn't really have any place to move. It doesn't have any give. Think now of the blood maybe leaking some blood or a blood vessel, a tear in the pericardium, leaking into that space. It will start filling with blood under pressure. The heart will squeeze, which makes it smaller, and then there's blood in the space, and the heart can't expand. So it can't refill itself. And this immediately and very quickly leads to what's called pericardial tamponade. A tampon is something that presses. Tamponade means that the blood in the pericardium is pressing against the heart. This is a very serious situation. It requires emergency treatment, or death will ensue depending on the severity in a very few minutes. The treatment for this is to open the pericardial sac. A surgeon will take a knife, open the chest, cut a hole in the sac, and let the blood out, and then if it's done in time, everything would be fine. In an emergency room or a place that doesn't have the ability to open the chest, you might stick a very large bore needle through the ribs, into the pericardium, and if the blood hasn't clotted, it could come out and relieve the pressure. So those are the structure and the function of the pericardial sac. And then we get to the layers of the heart, which is rather simple, not very complicated. The heart is basically a muscle. It consists of 3 layers that we define and look at as all being separate with separate functions. There is the epicardium, epi meaning outer, and as I've just pointed out, that's really the visceral pericardium. It's a shiny, thin layer that you can see through. It's that thin. It's quite tightly adherent to the heart muscle itself. And if you tried to strip it away in the dissecting room, you would actually tear pieces of heart muscle. It does not have any give. It's an integral part of the heart. On the other side, on the inner wall, is the endocardium, the inner heart lining. And this is also another very thin layer, only a few cells thick, that provides a very smooth surface for the flow of blood so that there won't be any drag. This layer is continuous with a layer that goes right out into all the vessels, which we'll talk about later, called the endothelium. The endothelium merely is the endocardium, where it goes out into the vessels and becomes the covering of the vessels for the very same purpose. Now, the myocardium is kind of interesting. This is the thick, strong muscle between those 2 layers that comprises almost all the bulk of the heart. And this is a very specialized kind of muscle. First of all, this muscle is one of 3 kinds of muscle we have in the body. Embryologically, we have smooth muscle, which we'll talk about a lot later, that is called smooth because of the way it looks under a microscope. It regulates sphincters. It causes the intestines to move when you digest food. Then there's 2 types of skeletal muscle. Skeletal muscle is called that because it is mostly in the parts of the body that move the skeleton. It's also called striated or striped muscle because under the microscope it has little stripes. And the myocardium is a form of skeletal muscle, but it's specialized. It has things that other skeletal muscle, for example, the muscles in my arms and legs, doesn't have. It has inherent rhythmicity. It will sit there and contract on its own without being told to at a specific rate. If you take the heart of an animal or human out and put it on the table with no nerves, no blood supply, but keep it moist and oxygenated, it will pump. And it will pump at an inherent rhythmicity that you can time. It also has another aspect to it. It is lined up, instead of being in straight long fibers, the way our muscles of our arm is, for example, when we contract our arm, it's in a spiral swirl and then twisted upon itself. So when the myocardium contracts, it squeezes the chambers to empty and eject blood. Now, the myocardium is not just one set of heart muscles. It has separate components. And when we look at the chambers of the heart, what we're going to see is we have an upper and a lower heart, and the muscles are separate in their function. They're attached, and the upper heart and the lower heart have different muscles. These muscles are, as I said, involuntary. They're autonomic, means self-naming, so you don't have control over them. There are people who can control their heart rate, but they usually do this by controlling breathing, by relaxation techniques. They can usually slow their heart rate that way, but they can't usually speed it up without actually doing something, releasing chemicals by, for example, exercise. So the rhythmicity in the heart is part of its inherent nature, and we're going to look at how they vary in different parts of the heart and what this means to the heart itself. So in summary, basically, you have this very small organ. It's about the size of my fist, weighs about a pound. It pumps blood through about 50,000 miles of vessels and capillaries. The Earth at the equator is 24,000 miles. This means you could string out all your vessels and capillaries in your body around the equator of the Earth more than 2 times. And before you used up all your vessels. It's an astounding amount of power that has to be delivered here. When we look at the heart, we're going to talk about lots of different divisions that are artificial divisions that we've made to define the heart. We talk about the systemic and pulmonary circulation, which we've already talked about. We talk about the right and the left heart. If you look at the pulmonary circulation again, and the systemic circulation, we arbitrarily divide the heart into the right and the left side. Not all that arbitrary, because physiologically and anatomically they work somewhat independently. The right side of the heart is the venous side, all the blood returning from the body, from the systemic circulation. The lower body, the head, the arms, comes back into the right side of the heart, completely devoid of any oxygen and depleted in nutrients. The left side is the side that pumps out to the body, to the brain, and to the upper extremities, and it is delivering oxygenated, nutritious blood to the body. Now, when we talk about the lungs, we have to modify that, and I'll talk to you a little more about that when we talk about the pulmonary circulation. What happened was that we developed this heart out of an embryologic heart that is really one of the most evolved, efficient machines in all of the animal kingdom. There's a saying, there used to be a saying that people used a lot, that said ontogeny recapitulates phylogeny. That's doctors showing off. This really means that the development of the human body through all its stages in embryology goes through all the stages that the animals did in evolution. A lot of people say this isn't really true, but it's a very convenient way to look at it. If you study embryology, you'll see there's a certain point in which we have gills, the way fish do, and they go away in time. There are lots of other structures that have very, very primitive beginnings that evolve through all the stages of evolution and eventually end up in the modern body that we have today. So if you look at the next slide, what happens in the embryo, in very early stages, we actually have 2 sets of straight tubes that are the precursors of the heart. These tubes eventually merge and join. And there are lower animals who have a heart that's as uncomplicated as this. Pumps in one direction, there's no mixing or separation, and it's a very much more primitive heart, and one It's not as effective in meeting stressful situations. As time goes on, the fusion becomes complete, and then the twisting begins. Remember, I told you that the heart muscle twists and turns so it has a better circular contraction. And finally, we end up in this primitive version of the four-chambered heart, which is very much twisted and a little hard to recognize as the heart we're talking about. I'm going to get to that in just a minute. There's also a major difference in the two sides of the heart in that the left side of the heart, which has to pump out to a circulation of all these miles of capillaries, force it through the blood bed and back into the body, the left side's going to be pumping a much higher pressure, probably about 4 times as much pressure as the right side, which is only pumping to the lungs. So the left side of the heart is much, much thicker. Its wall is 4 times as thick as the right side. The right side is only pumping out to the pulmonary circulation, and that side is just going to go through a very fine capillary bed before it returns the blood. And this side of the heart, though it doesn't show it so well here, this thickness of this ventricle is only about 1/4 of what it is on that side. And that's purely of necessity. Evolution only does what it has to do. It gives us just what we need and in the amount we need it. So you have two sides of the heart, the right and the left. They function separately and at different pressures, and they can actually fail separately. I'm going to talk about the pathology in the next lecture, but for the moment, think of them as two sides of the same organ that have very, very different temperaments, very, very different abilities. We then also have the heart divided, if you went right across here and think of the upper and lower chambers of the heart, they too have different functions. In the normal heart, we have 2 chambers at the top. Again, this is schematic, but I'll show you real drawings in the middle. These are called atria. Each one is an atrium, and you probably know from other uses of that term, it means a waiting room or a little room. This is the upper heart. Blood returning from the lungs goes to the left atrium, where it waits to be pumped out into the ventricle and then the body. Blood returning from the body to the venous or right side of the heart goes into the right atrium, and then it is pumped into the right side where it'll go back out through the pulmonary arteries to the lungs. It is very efficient this way. The functions are separated, and so this 4-chambered heart is a very, very important part of our system in terms of being efficient. Again, the right side is low pressure, left side is high pressure, and they have different capacities. Then we move down into the ventricles. Here's the left ventricle and the right ventricle. Ventricle means a little belly because it's a bulging out of muscle. And these are the power part of the pump. Both ventricles pump out enormous volumes, and the right side pumps it out to the lungs. The left side pumps it out to the body. And when you think about it, since this system is connected everywhere, it's like 2 big closed loops. Here's the systemic circulation from the left side of the heart and the pulmonary circulation. These 2 sides of the heart have to be absolutely matched perfectly to the minutest fraction of a drop per minute. Because if one side pumped more than the other, and once the other side didn't, no matter how small a difference there were, eventually the blood would all pile up on one side. Given enough beats, 60 or 70 beats per minute, hour after hour, day after day, eventually you're going to have a separation of the volume on one side or the other. And this happens in heart failure. And I'll talk a little bit more about that in the next lecture. So the atrial sides are separated by a wall, and the ventricular sides are separated by a wall as well. If we look now at something a little less schematic and more real, we get a picture of the heart here to review a bit. Here are the pulmonary veins coming back from both lungs. There's 2 big ones on each side, emptying right into the atrium through big, big openings. Here's a valve separating the wall, the two chambers, and then here's the ventricle pumping out through the aorta to the rest of the body. On the other side, you have two big veins, which we'll talk about in a couple of lectures from now, pumping into the atrium, into the ventricle, and out to the lungs. And that picture is a little more realistic. If we want to go a little further without bringing you a real heart, this is what it looks like with a very good artist rendering of the actual heart itself. Here's your thin-walled right side ventricle. Here's your thicker walled left side. Here's a septum in the middle. This is called the intraventricular septum, and it separates the two sides. Here's the outflow from the right side. Here's the outflow going behind it through the aorta on the left side. And then here is the blood coming back in to the right. And they're showing you a picture of the valves. This is the valve that separates the left atrium from the left ventricle. I'm going to discuss those in a second. Here's the valve in the aorta. Here's the valve on the right side and the valve on the pulmonary artery going back out to the lungs. There are openings between the two sides of the heart, which we won't get to great detail. Remember, when the baby is developing in the uterus, there is no oxygen circulating in the sense of air in the lungs. The lungs are collapsed. The baby has no access to air, gets all its oxygen from the mother's placenta. So the circulation is quite different, and actually there are holes in between the two atria that blood can get across, so circulation is complete. That closes shortly after birth. Occasionally that doesn't close, surgeon has to go in and sew it shut. Those are typically cardiac anomalies, which used to be very, very serious. Today with open heart surgery are virtually all correctable. Now, coming to the valves of the heart, this is another beautiful system that has evolved over many, many years. And the valves separate our four chambers. If we begin with this side, here is the left atrium, and there's a valve here called the mitral valve or the bicuspid. It just means it has two leaves. If you think of the way these valves work, they're kind of like parachutes. If you had parachutes pressed next to each other that were open and billowed out, you could force water or blood down between the parachutes and they would get out of the way. And then as soon as there was back pressure, they would come up if they were close enough and shut off backflow. They would have strings too to prevent them from flipping all the way up. And if you look, these valves have those strings on both sides. The mitral valve on the left side and the tricuspid valve on the right side, because it has three leaves. It would be like three parachutes. And these strings are called cordae tendineae, or tendinous cords, and they prevent the valve from billowing back and allowing blood to leak back into the upper chambers during the contraction phase of the ventricle. They also have little muscles down here called papillary muscles, which can tighten these strings as necessary. Those are the two valves that separate the upper chambers from the lower chambers. So when blood is rushing into the ventricle, the valves are open. And then when the ventricles squeeze on both sides, these valves shut to prevent backflow into the atrium, and these valves open up. Here's the aortic semilunar valve, meaning it has two half-moon shapes. And then the pulmonary valve also has half-moon shapes, and this one has three little cusps that you can see on this picture. Now, those valves don't have any cordae tendineae. They're in a much more constricted, tight, fibrous ring, and they don't need those cordae. They're just a different structure, but they do balloon, open and close, allowing blood to flow out and not allowing any to come back. So what can go wrong here? What kind of diseases can we get on the valves? The valves are very delicate. They look like fine, fine silk. And if you look at this picture of the valves, this is a pretty good drawing of what it would look like if you took it out. There's a fairly hard ring in the wall of the heart. And here's the parachute billowed back. So we have to presume that the blood during ventricular contraction can't go back into the atrium. but will go out the other end. Here's the tight chordae tendineae and the papillary muscles, which are contracted to hold it tight. During the phase where blood is rushing into the ventricle, here the valve is open. This one is the bicuspid or mitral valve. And here are the chordae tendineae, which are relaxed, and these papillary muscles are relaxed as well. What can go wrong with these valves? Well, one of the most common things that went wrong when I first went into medicine were patients who had rheumatic fever. People who had strep infections, usually strep throat, and didn't get treated in the pre-antibiotic days, had a disease called rheumatic fever, which damaged the valves. Primarily, it damaged the aortic and the mitral valve, but it could damage all four. And it could damage other single valves as well. But primarily, this was mitral valve damage, aortic valve damage. The damage could happen two ways. One, it could make the valves too tight so they didn't open well. That's called stenosis. Or it could injure them so that they were irregular and they couldn't close very well, and that was called insufficiency. So instead of this valve, for example, closing, it would be irregular along its edges, scarred and nodular, and blood would leak back. That caused inefficiency. Part of the blood we were trying to pump out to the body was now leaking back into the atrium. And the heart would have to pump harder with more force and maybe more speed in order to get the blood out. Same thing can happen on the other side or in any other combinations. In the old days, much of our surgery was related to removing those valves, taking out the damaged valve and actually sewing in what looked like a little wire basket with a ball that clicked back and forth as the valve opened and shut. You could actually sit in the room, in a quiet room, and hear the patient's valve opening and closing with a little click. Some patients actually told us it kept them awake at night sometimes. Today we have better valves that do this a little more silently, and more important, we've gotten rid of a lot of the rheumatic fever because we've been able to get the patients treated from their strep infections so we don't get rheumatic fever, and we hardly see this anymore except in the very old. There are other diseases such as mitral valve prolapse, in which this valve, the mitral valve, flops back and is slightly insufficient. It happens a lot in young women. It's often very asymptomatic. The patients are able to do exercise. They don't know they have it unless the doctor hears a murmur, and they get along perfectly well. It's only very few of them that have a problem with this that needs to be treated. Next, we need to go and look at the supply of the blood vessel to the heart itself and see how the myocardium gets its own blood to feed the myocardium and the tremendous energy output that it requires. If you look at this slide, immediately after the blood exits the heart, the first vessels it encounters are these two vessels, the right and the left coronary arteries. Come right off the aorta, and they come right back to the heart. If you look here, it comes down along the wall of the heart, giving off branches as it goes. Another one goes around the back called a circumflex on the back side of the heart. And here on the right side, it goes down between the atrium and the ventricle, giving vessels to the atrium and the ventricle. And if you notice in the back, they seem to connect. Now, this again is evolution at its best. One thing you don't want is to run out of blood supply for your heart. You absolutely have to have it. Also, vessels run into the septum and all the other areas of the heart. This brings us to the first use of the term anastomosis. And anastomosis is the joining of sets of blood vessels or other hollow structures, but in this case, blood vessels. And the heart is just filled with anastomoses. As you can see here, this one, which is a major vessel called the anterior interventricular branch, will join up with a posterior branch. So if this gets blocked here, blood might be able to come across this side and help it out. Blood direction and flow can change as pressures dictate. Now, one of the most common causes of death is obstruction of one of these vessels. and that can be a serious problem. It can cause death instantly, or you may have damage to the heart that can be correctable and survivable. And in fact, we can do things to help that. When this occurs, it's what we call a heart attack. In medical terms, it's called a coronary or myocardial infarction. Infarction is the death of tissue without the death of the body. So a piece of muscle can die without the patient dying. Many people survive. There's so much excess blood supply that it actually takes more than 70% narrowing of one of the major vessels before the patient will feel any symptoms and before you have any problem to worry about. The good side of that is we have a lot of reserve. The bad side is you may be very, very sick without knowing it. You may be on the edge of having to have your arteries replaced or bypassed or some other way of bringing blood in. And I'm going to go into that a little bit more in the next lecture. The veins are somewhat more simple. They have a very similar pattern, and they drain themselves right back directly into the atrium. There are little holes in the right atrium bringing the venous blood back into the right side of the heart for drainage. But basically, they parallel the arteries. We teach our medical students to learn all the names of the arteries, and then the veins just go along with them. Next thing we want to talk about, we've talked about the blood supply, the structure of the valves and the wall, is the conduction system of the heart. The heart is made of the muscle, as I said, which is inherently conductive. What happens in embryology is this muscle is different. It differentiates from other muscle in the body, and it further differentiates in that about 1% of this muscle becomes almost like nerves. They're not really nerves, but they are conductive. They can send electrical impulses the way a nerve can. Now, you can hear me talk about this a lot, but the nerves of the body and the muscles of the body are an electrical phenomenon. And the way they work is chemically. There are ions, which are charged chemicals such as sodium, potassium, calcium. They all have electrical charges. And when those ions move across membranes, they can propagate an electrical charge. In the nerves, it causes stimulation of something, the brain, the muscle, and in the heart, it stimulates the heart itself. These conductive fibers are what allow us to get impulses through the heart so the myocardium can contract. Now, if you look at this next slide, remember I told you there was different inherent rhythmicity in the heart. If you just took the heart muscle down here in the ventricles, it would have a rather slow rate, probably 20, 30, 35 beats per minute. That's not good enough to keep the blood in the body going at a rate that will allow life. Fortunately, up here, the rate is even faster. And we have a pacemaker up here in the wall, high on the right atrium, called the sinoatrial node. It's a little piece of highly specialized tissue that has a rhythmicity that is fast enough for us to be able to survive. It sends its impulse back to the rest of the heart using the fibers inside the muscle. And the circulation at first is right through the wall of both atria. Now, these fibers come together right here at the atrioventricular node, where, as you can see, if you look very carefully, things get very small. So these impulses get to the node and then go down through this very thin area and then to a big one again. This is like a traffic jam. It's a very purposeful traffic jam, again, that evolution has given us. The impulses will slow down, and I'll explain more of that in the physiology, but basically it is then distributed to all the sections of the ventricle and the musculature here to allow proper contraction. The ventricles are able to contract. First contraction goes through the atria to pump blood into the ventricles, and finally the ventricles to pump blood out of the heart and to the rest of the body. This is an extraordinarily sophisticated system. It has many, many things that are finely tuned to all situations, but it also has many, many things that can go wrong with it. And we're going to cover some of that in our next lecture on the physiology of the heart, so that we can understand how to put the anatomy together with all the things that can go wrong.